Hello, everyone. Welcome back to another day of our review session. We are on day 65 out of the 90 days, and you are welcome to join with us today for our review session. And we're going to do some drills about the pharmacological agents on the central nervous system. And we are also inviting you to enroll to our comprehensive NCLEX review course at Stancoast NCLEX Coaching, where you will be able to find a wealth of resources. We have about 3,000 NCLEX style questions and 20 hours of animated videos, which you can access 24/7 in your 6 months of subscription. So kindly visit www.stancoastandclexcoaching.com to learn more. And for additional details, click on the link below. And we also value your feedback, so kindly share your thoughts and your comments in the comments section. Now, don't forget to hit the like button, also subscribe to our channel, and also share this video to your friends who are preparing for the NCLEX. Now, let's get started with our first question of the day. Question number 1 states, a nurse is educating a patient with Parkinson's disease who is prescribed the anticholinergic medication Benztropine, or named as Cogentin. The nurse should inform the patient that the primary effect or primary benefit of this medication is A, increasing walking speed, B, enhancing cognitive function, C, reducing symptoms of slow movement, D, decreasing some tremors. Again, this is on a patient who has a prescription to use the Benztropine or the brand name Cogentin. So which of the education or instruction or what kind of teaching that you should share with this patient regarding the primary benefit of this drug? Is it A, increasing walking speed, or is it B, enhancing cognitive function, or is it C, reducing symptoms of slow movement, or letter D, decreasing some tremors? Take note, guys, that our patient has a Parkinson's disease, and I really want you to review onto what the characteristics of this disease. Okay, I really want you to review on that before you're gonna give your answer. Make sure that you are matching it with the expected therapeutic effect of the drug. And please take note about the classification of the medication, Cogentin. So if you had answered letter A, this is increasing walking speed. This is incorrect because the Benztropine is not effective at enhancing motor function, such as walking speed. The primary action of the Cogentin or the Benztropine is actually to reduce the tremors. It will reduce the muscle rigidity. So our correct answer here in this test item is letter D. Take note of that. It is to reduce the tremors. Also reduces muscle rigidity. It doesn't enhance letter A, so we are going to get rid of that. And take note, guys, about the medication classification. It is an anticholinergic agent, right? So when you're answering this test question about this drug specifically, you got to focus about its main therapeutic effect. It will manage those manifestations such as muscle rigidity and tremors. Those are the primary therapeutic effects. All right. Now let's have letter B, enhancing cognitive function. Will that assist or will that enhance the cognitive function? No. The Benztropine can actually impair cognitive function. It can also have side effects leading to confusion. It can also cause memory problems, especially in older adults. So this is totally incorrect. The side effect of this medication is confusion, can also decrease the cognitive function. So it is actually the exact opposite. Function, FXN, that's my abbreviation for function. Now, if we had selected letter C, reducing symptoms of slow movement, is that the desired effect of the cogentin? We know that it can decrease the tremors, right? But it is not effective in bradykinesia. It's not going to reduce the bradykinesia, which is actually going to be treated by another type of anti-Parkinson medication. So this is basically what we call as bradykinesia. And again, the medication does not reduce this manifestation. However, the bradykinesia is something that can be treated or could be alleviated by the use of the levodopa, not the cogentin. Okay, so please take note about the therapeutic effect. So our correct answer for this test item is letter D. This is incorrect. B is incorrect. A is incorrect. The same thing with letter C. For those who just joined us, welcome back to our class today. We'll be focusing more of the test questions starting today as well. Now let's move on. Let's have number 2. When preparing to administer the initial dose of Benztropine cogentin to a patient with Parkinsonism, the nurse should alert the healthcare provider if the patient has a history of A, asthma, B, glaucoma, C, high blood pressure, D, irritable bowel syndrome. So you as a nurse here is about to administer the first dose of cogentin to a patient with Parkinson's disease. But before you're going to give this medication, you should alert the medical provider if your patient has any of these medical history. Is it A? Is it B? Or is it letter C? Or is it letter D? Take your careful pick. All right, let's take a look into letter A, asthma. What do you think about asthma? Well, this is not typically contraindicated in the use of the cogentin. As we know that the anticholinergic medication does not cause the exacerbation asthma. Please recall the drug class, anticholinergic, does not have any effect in the bronchospasm. Take note of that. Now, let's take a look into letter D, irritable bowel syndrome. Will that contraindicate the use of the cogentin? We know that the cogentin can also affect the GI motility, but this is something that will not contraindicate the use of the cogentin. The medication itself, though, can lead to, or can, there is such, you got to be careful, though, when you are administering the anticholinergic cogentin to a patient that may have bowel obstruction. But in this case, it's not really a contraindication. So we are going to eliminate the IBS. What about letter C, high blood pressure? Do you think that the cogentin is contraindicated with this drug? No, this is also incorrect because the anticholinergics do not directly affect the regulation of the blood pressure. Okay, it doesn't cause high blood pressure, and it is not contraindicated in a patient that is hypertensive as well. So we have our last option, which is letter B, the glaucoma. Take note, guys, if your patient has a case of glaucoma, you got to be careful. Make sure that they are not going to use this type of anti-Parkinson medication because it can increase the intraocular pressure. Cogentin can increase the intraocular pressure. Any kind of medication that contains anticholinergic, or if it has anticholinergic property, this is something that you should check with the medical provider. You got to question that order because it can lead to an aggravation of increasing IOP, especially the narrow angle type of glaucoma. So take note about the contraindication. You gotta check first with a medical provider in order to avoid any aggravation of the IOP increase. Let's move on, guys, to number 3. A patient with Parkinsonism is taking trihexyphenidyl, or known as Artane, and reports having a dry mouth. The nurse notes the patient has had a urine output of 300 mL over the past 8 hours. What should the nurse do? Is it A, advise the patient to drink more fluids, B, request an order for intravenous fluids, C, inform the healthcare provider of the low urine output, and letter D, ask for renal function tests to be ordered? Take note, your patient now is getting a prescription for the trihexyphenidyl, or known as the Artane. But now, he is now complaining of the dry mouth. And you are noticing that the patient's urine output is only 300 mL for the entire 8 hours. What should you do in this scenario? Will you advise the patient to drink more fluids, or will you get an order for IV fluid infusion? Or are you going to inform the medical provider because of the low urine output? Or is it D? Will you ask for an order to check for the renal function? Your answer? All right, while you are looking for that answer, let me start with letter A. Advise the patient to drink more fluids. Would that be appropriate? We know that taking more fluids can alleviate their dry mouth. Yeah, that is a complaint of our patient, the dry mouth. But you, as a nurse, observe that there's only 300 mL of urine output for the entire 8 hours. The problem here in this scenario is the urinary retention. Take note, whenever you have a patient that has a prescription of this kind of medication, it can lead to urinary retention. So it also has the anticholinergic property, right? So this is not going to address the urinary retention, not addressing concern. So we are eliminating that one. What about letter B? Request an order for intravenous fluid. The same thing. Even though the route of IV fluid intake is through the IV, it doesn't also address the urinary retention. If you had answered letter C, inform the healthcare provider of the low urine output. This is the correct answer. All right. So the patient possibly in this scenario is having a urinary retention, which is a potential side effect of the Artane, right? And this will require for additional assessment and also intervention by the medical provider. So this is the correct answer. What about letter D? Ask for renal function tests to be ordered. Well, that could be a possibility, but first things first, you got to have to inform the medical provider about that low urine output. This is an abnormal assessment. Take note about the normal range of the hourly urine output, which is basically about 30 to about 50 mL per hour. This is an abnormal assessment that you should report to the medical provider. Okay. Now, if you are doing letter D first before actually, or if this is the main, if you're going to take this letter D instead, it doesn't really, it doesn't address the main issue, which is basically the 300 mLs of urine output for the 8-hour duration. Okay, make sure that they are aware first about the problem before they're going to have to provide you with additional orders. Okay, this could be a possible order, but again, we need to inform them about the abnormal urine output. Okay, so we need to consider the type of medication that the patient is using, and also you prioritize those interventions that are based most likely caused by the symptoms. But urine out is in normal range. 300 mLs over the past 8 hours. Let's take a look. Let's take a look about the 300. Does that 3 divided by 8 hours? That's about 37. Yeah, you're right. That is a possibility that the patient's urine output is actually within the range. That's correct. 300 mLs over the past 8 hours. So what should the nurse do? Okay. This is basically around 37 mLs per hour. Take a look into your calculation, 37.5. Quite on the low side. It is on the normal range. But take a look into the side effect. What we are being asked here, guys, is about the urinary retention. We are not being asked about the function of the kidney. The patient is taking an anticholinergic drug that is actually going to cause urinary retention. It is going to affect the emptying of the urine in from the urinary bladder. We're not worried about the kidney function here. It isn't the problem that is being suspected in this scenario. What we are worried here is about the urinary retention. So if your patient has the Artane in their prescription, even though you think that this is within the normal range, the patient will have a tendency to retain more urine in their bladder. So that is basically what this question is asking. It's not about the hourly, what do you call this? The perfusion to the kidneys. All right. So even though it said low urine output, it doesn't really, it's not directly pointing out about the kidney function, but rather the output because of the low output, because of the retention, the relaxation of the urinary bladder. So this is the correct answer, letter C. Okay. So it's kind of stated weird. However, the main concern here is really about the urinary retention. So number 4, the question here. A nursing student inquires why patients with Parkinsonism are given a combination of carbidopa and levodopa. The nurse should explain that combining these medications can A, permit higher doses of levodopa without increasing the side effects. B, increases the conversion of levodopa to dopamine before it crosses into the brain. And letter C, reduces nearly all adverse reactions from both drugs. Letter D, minimizes peripheral side effects by blocking decarboxylase outside the brain. So your nursing student is asking why patients with Parkinson's are given with both the carbidopa and the levodopa. So what would be your explanation regarding this combination? Will that be letter A, that it can permit higher doses of levodopa without increasing the side effects? Or will that increase the conversion of levodopa to dopamine before it crosses the brain? Or is it C, reduces nearly all adverse reactions from both drugs? Or is it letter D, minimizes peripheral side effects by blocking decarboxylase outside the brain? I'm only seeing two answers this time. So you answered letter B, increases the conversion of levodopa to dopamine before it crosses into the brain. That answer is incorrect. Why? Let me show you. So when a person is taking just the levodopa, for example, the medical provider's prescription is 500 milligrams. So this is just mainly levodopa, right? No carbidopa involved. So about 70% of the levodopa can be metabolized already when it reaches the GI tract. So the remainder of that medication, or actually the portion of the drug, which from 500, there is about 350 milligrams of that dose that is already broken down. And this is no longer available to the brain, right? And aside from that, before the medication reaches to the brain, about 140% milligrams is already metabolized. It is already broken down. And the remainder of that medication that will reach into the brain after it crosses the blood-brain barrier, there's only about 10 milligrams left, or 2% of that 500 milligrams. Okay, so what is really the role of the carbidopa here? So, for example, the medical provider only prescribes 100 milligrams plus with that 25 milligrams of the carbidopa. That carbidopa actually has a protective effect. It will somewhat kind of preserve the amount of the levodopa before it reaches to the brain. It will prevent the massive breakdown or metabolism by the GI tract. So about 40% of the levodopa is metabolized, which is equivalent to 40 milligrams, right? And 50 milligrams of that levodopa is also metabolized by the peripheral tissues. So that simply means that 50% of the levodopa that was ordered is no longer available to the brain. So by the time that the levodopa crosses the blood-brain barrier, there's about 10 milligrams that will reach into the brain. This will be converted into the dopamine. So again, the action of the carbidopa here is basically to prevent the action of the decarboxylase in the intestine, which is responsible in the metabolism of the drug. So let's go back into this question right here. If you answered letter A, permits higher doses of the levodopa without increasing side effects. Is that correct? Well, this is incorrect, guys, because the combination of the levodopa and the carbidopa is not intended to allow higher doses of levodopa. But it allows the same effects at lower doses. Thus, it actually will reduce the peripheral side effects. It will also enhance the availability of the levodopa in the brain. So basically, the medical provider will be able to order a lower dose of the levodopa, so there will be less side effects as well. All right, so this is not a correct statement. Permits higher doses of levodopa without increasing the side effects. This is incorrect. So if you answered letter C, reduces nearly all adverse reactions from both drugs, this is also incorrect. Because again, the role of the carbidopa here is to reduce the peripheral side effects. It does not eliminate all adverse reactions. The statement here, all adverse reactions, is erroneous. It doesn't, okay? It will only reduce, but not all adverse reactions. So we don't have any other option but letter D, okay? Take note, guys, that in the diagram that I presented to you, the medical provider will be able to order such lower dose of the levodopa together with the carbidopa. And this is to also minimize the side effects, okay? So take a look into the difference here. 500 milligrams of the levodopa, however, only about 10 milligrams will be able to reach to the brain because of that enzyme that breaks down the levodopa, okay? Let's have number 5. A patient with Parkinsonism is starting Selegiline, or known as the Ildipril, to help manage their symptoms. Now, which advice should the nurse provide regarding this medication? Is it A, avoid foods rich in tyramine? B, this medication eliminates the need for levodopa? Or is it C, having a glass of red wine occasionally is acceptable? Or letter D, there are no major drug interactions with this medication. Is that correct? So take note about the drug Selegiline. I really want you to recall the drug classification, so you'll be able to know what to be cautious about. Are there any drug interactions that you should be thinking ahead, or will there be some caution regarding the diet or whatever drinks that they may have? Will you have letter A, avoid foods rich in tyramine, or is it B, this medication eliminates the need for levodopa, or is it C, having a glass of red wine occasionally is acceptable? And D, there are no major drug interactions with this medication. So guys, what is your answer? I'm seeing Boss Babe answering D, and then you changed it to letter A. Okay. All right, let's have letter A this time. Avoid foods rich in tyramine. This is the correct answer. Why? What is the classification of our Selegiline? The drug class is the mono. This is what we call as the MAO-B inhibitor. That is the monoamine oxidase B inhibitor, which can cause the hypertensive crisis whenever the person will be taking any tyramine-rich foods, right? Hypertensive crisis. So what are those foods that are tyramine-rich containing? Well, red wine is actually one of those. Cured meats, aged cheeses, and there's so much more. So recall all those food items that are contraindicated in a person taking the MAO-B inhibitor. They're not supposed to take any of these food items when they're taking the MAO-B. If you had answered letter B, this medication eliminates the need for levodopa. Is that a correct statement? We know that the Selegiline may delay the need for the levodopa, but it doesn't really eliminate the necessity of having that medication in the future. It can delay the need, but it's not going to eliminate the need of this drug in the future. It is incorrect. If you answered letter C, having a glass of red wine occasionally acceptable, no, it's not acceptable. It can lead to the hypertensive crisis. What is it? Please. Oh, okay. That's fine. Thank you, boss babe. Alrighty. Now, letter D. There are no major drug interactions with this medication. Is that correct? No major drug interactions. Actually, there's many drug interactions associated with the Selegiline, especially when they are going to take any tricyclic antidepressants or maybe the SSRIs. This can lead to the serotonin syndrome or can also lead to hypertensive crisis. Serotonin syndrome. So this statement right here, no major drug interactions, is false. There are. These are your TCAs and the SSRI. Okay, so our correct answer this time, it is letter D. Alrighty, guys, let's have number 6. A patient receiving a combination of Entacapone or COM10 and Carbidopa-Levodopa reports orange-colored urine. How should the nurse respond? Is it A, alert the healthcare provider about possible drug toxicity? Or is it B, reassure the patient that this is a normal side effect? Or C, order liver function tests to be conducted? Letter D, request urinalysis to be performed. Your patient is taking COM10 and also Carbidopa-Levodopa. Now they are noticing orange-colored urine. How are you going to respond to this complaint? Will you do letter A, alert the healthcare provider about the possible drug toxicity? Well, that is incorrect, guys. The change in the patient's urine color is a benign side effect. This is expected. Expected side effect that is benign. Nothing to worry about the change of color. No, you should not call or alert the medical provider for this one. Okay, so guys, I really want you to go back into the pharmacology, the side effect of the drug. You gotta familiarize or refamiliarize the harmful side effects and those that may indicate potential harm. So take note of that. Harmful versus non-harmful side effects. So this is a benign side effect that we should not be worried about. We need to educate the patient, though, that they will be having a change in their urine color. If you answered letter C, order liver function tests to be conducted, is this necessary for this complaint? Well, there is no evidence suggesting that there is impairment of the liver function. The urine discoloration is a benign manifestation, so there's no need to obtain an order regarding liver function testing. And letter D, request a urinalysis to be performed. Well, what was the reason for that one? Is there any concrete reason why you should be conducting urinalysis? No, the discoloration again is a benign side effect. It is not going to require testing of the urine for this patient. So what we should do instead is reassure that this is a normal side effect, something that the patient should not be worried about. So our correct answer here is letter B. Let's head into question number 7. An 80-year-old patient with Alzheimer's disease is about to begin treatment with rivastigmine or Exelon. What should the nurse include in the patient's care plan? A, administer the medication once each day. Or is it B, help the patient when standing and walking? Letter C, take the drug with food to enhance absorption. Or letter D, use NSAIDs instead of acetaminophen for pain relief. So the case is here of a patient that is an 80-year-old with Alzheimer's disease and about to start taking the Exelon, which is the rivastigmine. which is an anticholinesterase, right? So what should the nurse include in the care plan? Are you going to administer the medication once each day? Or will you help the patient when they are standing and ambulating? Or are you going to have them take the drug with food to enhance the absorption? Or is it letter D? Have them use the non-steroidal anti-inflammatory drugs instead of acetaminophen for pain relief. So while you're picking your answer, let me have letter A. Administer the medication once each day. Well, as per recommendation and according to the pharmacology, the rivastigmine should be administered twice daily. This is BID, not once a day. And it has to be taken according to the prescription to maintain the therapeutic drug levels, okay? And our option here is incorrect. The goal of the therapy here is to achieve that therapeutic level, making sure that the dosing schedule is taken twice a day to achieve regular, consistent drug level of the rivastigmine. If it is only taken once a day, it will not be able to maintain that therapeutic drug effect. What if we're going to take letter D, use NSAIDs? Will this really matter in taking the rivastigmine? Well, what can happen here instead is that the NSAIDs can increase the gastrointestinal side effects when taken with rivastigmine. So, acetaminophen is actually preferred for pain relief to minimize the side effects. So this is basically a wrong statement. Use NSAIDs instead? No, it is supposed to be the exact opposite. Again, because the NSAIDs can increase the GI side effects when taken with rivastigmine. GI side effects with NSAIDs. However, this is going to be diminished. The GI side effects will be diminished when the rivastigmine is taken with acetaminophen for pain relief. It doesn't mean that they have to be taken all together or at the same time, but the use of acetaminophen for pain control when they are taking the anticholinesterase, the side effects will be much lesser. Okay? Now let's have letter C. Take the drug with food to enhance absorption. Do you think that this can enhance the absorption of the medication? No. This is incorrect. It should be taken in on an empty stomach, rather. Should be taken on an empty stomach for absorption. There is much better absorption if the patient will be taking the drug on an empty stomach. If it is taken with food, then the availability of the drug will be much lesser because it can interfere the absorption in the GI tract. So what is the correct answer here? It will be letter B. Answer is letter B. Why? The patient that will be taking the anticholinesterase or the rivastigmine, they are at risk to falls because of the side effects. Rivastigmine side effect. One is dizziness and also unsteady gait. So letter B is our best choice for this question. Help the patient when standing and walking because of its side effects, the dizziness, and unsteady gait. All right, guys, don't forget about the side effect about the anticholinesterase. The same thing with the other family of anticholinesterase agents. Do not forget that. This is going to be useful when you are going to answer those questions about myasthenia gravis, since they're going to use the anticholinesterase drug classification as well. Let's have number 8. A patient with myasthenia gravis who is taking pyridostigmine bromide 60 milligrams every 4 hours has received a dose 45 minutes ago. The nurse notices that the patient is experiencing severe muscle weakness, excessive saliva production, muscle twitching in the face, and constricted pupils. What should the nurse do next? Is it A, check the patient for drooping eyelids, B, contact the healthcare provider about starting IVIG, or is it letter C, get an order for atropine sulfate, or is it letter D, ask for an additional dose of pyridostigmine? What is your answer here? Your patient now has a scheduled dose of mestinone for the myasthenia gravis. And it stated here that he had received a dose of dose of that medication 45 minutes ago. But at this point, you are already noticing that he is experiencing the muscle weakness that is severe, plus excessive salivation. There's also twitching on the face and constriction of the pupils. If you had answered letter A, check the patient for drooping eyelids. Would that be a crucial assessment to do? Guys, your patient is already taking the pyridostigmine. This is a classic example that your patient is having the cholinergic crisis. Way too much of that medication. Again, please don't forget, cholinergic crisis is caused by an excess in the dose of the anticholinesterase medication. So if you are checking the patient's eyelids, drooping eyelids, this is not really going to help, because the ptosis is observed in myasthenic crisis, not cholinergic crisis. Seen in myasthenic crisis, not in cholinergic crisis. So this is not going to help. And also, when the patient is in a cholinergic crisis, what are those manifestations that you should recall? Remember about the hypersalivation. And around this time, the patient has way too much acetylcholine. Acetylcholine increase. You have way too much of that. So we need to treat the excessive acetylcholine. So what are we going to do? We are going to get a hold of the medical provider to administer the atropine sulfate, which is an anticholinergic drug. Anticholinergic agent, which is to reverse the increasing effects of the acetylcholine. That is our answer this time. Okay. So what do you think are the other manifestations of the cholinergic crisis? Aside from the muscle twitching in the face, constriction of the pupils, excessive salivation, there's also that what? That's pretty much it, right? The constriction of the pupils, the fasciculations, basically that is our twitching. Fasciculations, don't forget that. The twitching of the muscles in the face, muscle weakness. And again, don't forget, there is no ptosis in the cholinergic crisis. If you answered letter B, contact the healthcare provider about starting IVIG. This is going to be used in a patient with a myasthenia gravis, not cholinergic crisis. Again, the IVIG is indicated for a patient that has the myasthenia gravis manifestation. Okay. This will remove those antibodies that are present in the blood. Okay. Or it will actually not really replace, but it will modulate rather the immune system. Modulates the immune system. Since the antibodies here are in a hyperactive state when there is myasthenia gravis exacerbation, so the IVIG is going to be one of the interventions to modulate the effects. Now, if you had answered letter D, ask for an additional dose of pyridostigmine. This can worsen the cholinergic crisis. Worsens cholinergic crisis. So we are going to eliminate that as well. So our correct answer here, it is letter C. Get an order for atropine sulfate. Now let's move along here for our item number 9. Patient showing significant muscle weakness receives iduronium bromide and experiences noticeable improvement in muscle strength within minutes. Which medication is the nurse likely to prepare next? Is it atropine sulfate, B, iduronium bromide or tensilon, or is it C, intravenous immune globulin IVIG, or is it letter D, pyridostigmine hydrochloride or the mestinon? So what would be the best treatment for this patient that is already confirmed to have the myasthenia gravis? It said that the patient had noticeable improvement in their muscle strength within minutes after the medication has been given to them. If you had answered letter A, atropine sulfate, that is incorrect. Why? If you are going to answer an anticholinergic agent, this can actually worsen the issue. The patient here basically has myasthenia gravis, not cholinergic crisis. So the atropine sulfate will not work for this patient. Now, if you had answered letter B, we know that the iduronium bromide or tensilon is an anticholinesterase, but this is not intended to treat a patient with the myasthenia gravis for an ongoing treatment. This is only a diagnostic medication. This is only used for testing, okay? This is a short-acting anticholinesterase. It's not used to treat myasthenia gravis. If you had answered letter C, intravenous immune globulin, will that be the best choice? Well, this is one of the treatments though, but it is only reserved for the severe exacerbations of myasthenia gravis. Intended for myasthenia gravis exacerbations. Severe. I forgot to put severe exacerbations. So our correct answer here is letter D, mestinon. This is a long-term type of drug that can manage the patient's muscle weakness. Okay, it can improve the muscle strength, and this is going to be the mainstay in the treatment of the MG. Correct answer here is letter D. Let's move forward. Question number 10. A patient with multiple sclerosis is experiencing an acute flare-up of symptoms. Which medication will the nurse likely administer? Is it A, adrenocorticotropic hormone or ACTH? Is it B, cyclophosphamide or Cytoxan? Letter C, glatiramer acetate, or known as the Copaxone. And letter D, interferon B. The situation here is on a patient with MS and has an acute flare-up. And don't forget, guys, about that lecture that I presented to you about the MS. There's that medication that we should be giving to treat the manifestations during the exacerbation period. This can treat, it can reduce the symptoms during that acute phase. However, we also have the other groups of medications that will be used for long-term to prevent the remission. And so they're not going to be useful during the acute phase. So if you had answered letter D this time, interferon, will that be helpful during the acute phase or flare-up? No, it is not going to be useful this time. We know that this is one of the treatments, right? This is what we call as the disease modifying therapy. So the purpose of the interferon is to decrease the frequency and also the decreasing the severity of the relapses. Decreases frequency and relapse of MS. It is not going to treat acute exacerbations. What about letter C? Glatiramer or the Copaxone. Will that be useful during the acute phase? No, it isn't. It is going to be useful for long-term management. It will also reduce the frequency and the relapse, but not useful during the acute period. What about letter B? Cyclophosphamide, Cytoxan. We know that this is part of the immunosuppressant therapy, right? Yes, it is going to be part of the management, but it is not useful in the acute phase, but rather it will be much more beneficial for chronic management of MS. So the three medications right here, B, C, D, are part of the treatment, but they're not effective during the acute phase. So we only have letter A as our answer. That is a steroid medication. Always think about the steroid, which is going to be used during the flare-ups or the acute phase of the MS. It will reduce the inflammation and also modulate the immune response. Reduces acute inflammation, and it will also modulates the immune system. Okay. We are talking about acute flare-ups. So the manifestations here will be kind of sudden. It will be debilitating for this patient at that current time. So we need to reduce those manifestations by the use of the steroid-based drug. So our correct answer here, it is letter A. Let's have number 11. I think we still have time. While preparing to give phenytoin to a patient with a seizure disorder, the nurse observes that the patient appears sleepy. The most recent serum drug level was 18 micrograms per ml. What should the nurse do next? Is it A, administer the dose since the patient is not toxic? B, discuss reducing the phenytoin dose with a provider? Or is it C, give the medication and monitor for side effects? And D, report phenytoin toxicity to the provider? So you are the nurse preparing the Dilantin to a patient that has seizure disorder. And the recent drug level of the Dilantin is 18 micrograms per ml. What would be your action this time? Will that be A? Will that be B, C, or D? While you're selecting, let me have letter D. Report phenytoin toxicity to the provider. Does that really pertain to toxic level? 18? Okay, letter D. Report phenytoin toxicity. It is not indicating toxicity. 18 micrograms is not in the toxic side yet. So the drug level for this patient is still within the therapeutic range. So reporting this as a toxic level to the provider is wrong. All right. This is incorrect. If you had answered letter C, give the medication and monitor for side effects. Are you really going to monitor for the side effects at this point, since the medication is still within the therapeutic range? There is no need for us to really increase the monitoring. So as usual, you're going to have to just observe the patient, keep monitoring, but not really excessively monitoring the patient for more side effects. Okay. The patient is still within the therapeutic range. Letter B, discuss reducing the phenytoin dose with the provider. Is there a need to reduce the dose? I don't think so. The level of the patient's dilantin is still within the therapeutic range, so there is no need to do some adjustments. So we have the correct answer here, which is letter A. Administer the dose since the patient's dilantin level is still within the normal range, and that is 10 to 20 micrograms per ml. Close to the upper border though, but there's no need to report toxicity. There is no such thing as toxicity in this level as of yet. So our correct answer here is A. Take note about the therapeutic level of 10 to 20, guys. Number 12, a nurse is preparing to administer phenytoin intravenously to an 80-year-old patient with a seizure disorder. The order reads IV push, phenytoin 50 milligrams. What should the nurse do? Is it A, give the undiluted medication through a Y tube over 2 minutes? Or B, call the provider to verify the dose and route? C, mix the dose or mix the drug in a dextrose solution and infuse over 15 to 20 minutes? And letter D, ask for an intramuscular administration order. Your patient is elderly, having that seizure disorder, and you have an order to administer dilantin or phenytoin 50 milligrams IV push. What are you going to do here in this scenario? If you had answered letter D, ask for an intramuscular administration order. Will this help the patient? Guys, take note. We are talking about phenytoin IV. The medication itself is going to be irritating, especially if we are not observing the correct administration. If you are rapidly giving it through the IV route, it can cause infiltration. Again, I said rapidly. So if you are going to ask for an IM route instead of the IV, what do you think can happen? This dilantin can cause tissue irritation. And this is supposed to be avoided. IM injection should be avoided. All right, do not administer IM dilantin. It can lead to tissue irritation, especially the muscle. If you had answered letter C, mix the drug in a dextrose solution and infuse over 15 to 20 minutes. A big no-no. You're not supposed to mix dilantin with anything containing dextrose. And the reason for that is the precipitation. You don't want to give sugar with the dilantin. Precipitation in the IV line and also in the bloodstream. We don't want that in our patient. should not be mixed with dextrose. We are only, if you're going to prepare your own solution. For example, if there's no available pharmacist at that time on your shift, so you got to do your own mixing. We call that as a mixture. You're only allowed to mix it with normal saline, 0.9%, not dextrose. Again, because it can lead to precipitation. If you had answered letter B, call the provider to verify the dose and route. The dose is not, it is actually in the recommendation schedule. It's not against the dose for this age, okay? It is appropriate. And so we are going to administer this medication without question. The verification is unnecessary in this scenario. So what are we going to do? We are going to give the phenytoin IV through the Y tube over 2 minutes. Yes, that is the correct administration of the drug. Typically around 2 minutes or a little bit longer. I usually give it a little bit longer, maybe 3 minutes. Slower rate is desired for this medication, okay? However, you got to take note that the drug should not exceed, or let's say you should not administer the medication. Let's say, for example, if you're pushing way too fast the drug, okay, maybe you are only giving the IV push in about 1 minute and 30 seconds. Well, that's not a safe practice. It can lead to bradycardia. If given less than 2 minutes. And we are talking about a 50 milligrams, right? So usually the recommendation in pharmacology is to give 25 milligrams in 1 minute. So basically, if we are giving 50, that should be 2 minutes IV push, not less than 2 minutes for the 50 milligrams because it can lead to the bradycardia. Alrighty. Let's just finish off our remainder of our test questions. A patient taking phenytoin reports frequent alcohol consumption. What range would you expect the patient's serum phenytoin levels to fall into? So you are taking care of a patient that is taking Dilantin or phenytoin, and they also take alcohol frequently. So in the choices here, you will select that phenytoin level. What do you think would be the expected phenytoin level if they are regularly, or let's say frequently, taking alcohol while taking the Dilantin or phenytoin? So what would be the expected serum drug level of your patient's Dilantin in the bloodstream? Would that be A, 5 to 10 micrograms per ml, or is that B, 10 to 20, or is it C, 20 to 30, letter D, 30 to 50? Take your pick. Now, if you had answered letter A, 5 to 10 micrograms per ml, this is the correct answer. Why? The alcohol basically can increase the breakdown of phenytoin, increases metabolism of phenytoin. What does that mean? Well, the available amount of the Dilantin in the bloodstream will be subsequently decreased, again because of the rapid breakdown of the medication caused by the alcohol. It will compete with the metabolism, actually. So it is expected that the patient's Dilantin level will be decreased. All right, that is 5 to 10 micrograms per ml. And as we know that the therapeutic level should fall between 10 to 20 micrograms per ml. This is the desired range that we should have for a phenytoin. But then again, the patient is taking alcohol frequently. This drug, or this alcohol rather, can cause more breakdown of the phenytoin. So it will be not so therapeutic for this patient. If you had answered letter B, that is incorrect, because it is expected that the alcohol alone can increase the breakdown of phenytoin. And letter C, 20 to 30, as we know that it can increase the breakdown of phenytoin, it is not expected to cause a rise in the dilatin level in the bloodstream. And the same thing with 30 to 50, which is basically a toxic. These are all toxic levels, right? These are not expected in a patient that is taking alcohol frequently. All right, it will significantly reduce the available dilatin in their bloodstream. Number 14, a patient on carbamazepine or Tegretol for refractory seizures has a serum drug level of 18 micrograms per ml. What should the nurse do? Is it A, inquire about the patient's dietary habits, or B, reassure the patient that the drug level is therapeutic, or is it C, report a low drug dose to the provider, or D, consider a possible drug interaction? Your patient that has refractory seizure simply doesn't really respond to other modalities of treatment, right? So they are now taking carbamazepine, but the level is 18 micrograms per ml. What are you going to do in this scenario? Now, before you're going to answer this one, you need to recall the therapeutic level of the carbamazepine drug levels. So if you are seeing 18, what does that mean? Is that within the normal range, or is it subtherapeutic, or is it way too high? So you really need to get back, you need to really recall the normal range of the Tegretol. So if you had answered letter D, consider a possible drug interaction, will that be a correct answer? We know that the interactions with other medications can also alter the drug level, right? The carbamazepine. But here, our patient's drug level is actually high. The expected therapeutic value of the carbamazepine is supposed to be at 5 to 12 micrograms per ml. Therapeutic level is only 5 to 12. Our patient's value is 18, which is more than the required drug level. So if you had answered letter A, inquire about the patient's dietary habits, this is part of your investigation. You got to ask them, what are you taking, or what are you eating when you are taking the medication? Are you taking any other substances that could potentially increase the drug level of the medication, or the drug level of the carbamazepine rather? So this is a question about assessing what they are taking together with the drug. So this is to assess drug interaction. And possibly they might be food drug interaction. So there's a possibility that they might be taking grapefruit juice. Yeah, this can increase the drug level of the carbamazepine. So what is the role of the grapefruit here? This will inhibit the enzyme that will metabolize the drug. Again, the grapefruit will inhibit the enzyme that is supposed to metabolize the carbamazepine. So the patient will end up with higher levels of the tegretol, and this is going to cause toxic effects. So this is the correct answer. If you answered letter B, reassure the patient that the drug level is therapeutic. That is false. We know that the value is already elevated. If you answered letter C, report a low drug dose to the provider. Mark that as incorrect as well because the value is way too high. And letter D, consider a possible drug interaction. Like I've said earlier, it can alter the serum levels, but in this scenario, it is most likely that the patient is taking some food items that can potentially increase the carbamazepine level. Alrighty, not about drugs. Let's have number 15. A nurse is conducting a health history for a patient about to start valproic acid, Depakote, for epilepsy. Which part of the patient's history is most concerning? Is it COPD, B, gastrointestinal disease, C, liver disease, D, kidney disease? So your patient is supposed to start taking valproic acid, Depakote, and you are obtaining the medical history of your patient. So which of those information, medical history, that would be concerning if they are supposed to take the Depakote? Is it the COPD? Is it the GI disease or the liver disease or the kidney disease? If you had answered letter A, COPD, we know that the COPD can affect the respiratory function, but it doesn't affect directly the valproic acid. Okay? It doesn't have an impact on the valproic acid. What about letter B, gastrointestinal disease? You think this is significant? Gastrointestinal disease and valproic acid, are there going to be possible issues? There is no significant GI issues that can contraindicate the use of the Depakote. There's not really a primary concern here. However, if your patient may have a history of liver disease, we know that the valproic acid can elevate the liver function tests. Valproic acid increases LFTs. So what we're going to look for here are those liver enzymes AST, ALT. And if they have a significant history of liver disease, they are going to need some more evaluation. They are going to be at a higher risk to developing those complications. So this is something that would require more investigation, possibly screening the patient if of their kidney function, not kidney, but liver function rather. So we should have an order to follow up or get an order to have a more recent LFT value, both AST and ALT. So this is a correct answer. Kidney disease. Will this be a significant history for this patient that is about to take valproic acid? We know that kidney function is also important, right? But the primary site of the metabolism for this valproic acid occurs in the liver. So our worry here is more about the liver function, not about the kidney disease. So this is what we should prioritize this time. Have that information relayed to the medical provider so at least they can do some more testing, check liver enzymes, and that's it. All right, guys, that's the end of our drill for today. We will be having some more exercises tomorrow, and we'll be tapping fluids and electrolytes imbalances, part 1. So I hope that you'll be coming back tomorrow's lecture, and also not really lecture, but this is going to be more Q&As from here on out so we can prioritize those. And again, thank you for your time today, and hope that you had learned something from this drill as well. And again, I am reminding everyone to enroll to our NCLEX course via www.stancoastnclexcoaching.com. We have updated our on-demand video lectures and also the animated video series. And this is something that you can access for the entire 6 months with your subscription. And we have all those NGN test questions at 200. We have them at 200 count, and also 3,000 NCLEX test questions. And along with the other available materials, we have the ebook, the flip book as well, and the audiobook. So again, we are inviting you to enroll, and click on the description box below to know more about us. Again, thank you, and you all take care. Bye-bye.